thanks to Stan and the organizing committee for inviting me. It's a pleasure to be here. And I was tasked with talking about anti-VEGF, where we are. And to talk about it, kind of have to go back a little bit in history, then talk about current, and then go forward to the future. Since this is a CME event, this is the mandatory disclosure slide. So what's VEGF? You've all heard of VEGF. It stands for vascular endothelial growth factor. Promotes blood vessel growth for good and for bad. Physiologic, embryogenesis, wound healing, bodily repair, such as in the GI tract, but also pathologic in terms of macular degeneration, diabetes. It also increases vascular permeability, and originally it was called vascular permeability factor before they came up with the name of VEGF. There are different types of VEGF. It's not all one VEGF. There's A, B, C, and D, and placental growth factor, and they all have different roles. Primarily, it's VEGF-A that we're concerned about in the eye. The others have roles in embryogenesis, lymphangiogenesis, and are probably less important. So, good, bad, and confusing, and it does get very confusing. Endothelial cells have receptors. There are different receptors that match different forms of VEGF, and different VEGF go to more than one receptor. So it gets a bit tricky there what you're blocking. Once the VEGF hits the receptor, it causes a cascade of reactions in the cell, and that's what leads to trouble. And on the right, you can see some of the different factors that are involved in angiogenesis. Tumor growth is an important one, and hence this was the approval for Avastin originally. Avastin is an adjunct to chemotherapy for various forms of cancer. Stifling the blood vessel growth will slow the cancer. But there are other conditions as well in terms of macular degeneration, diabetes, edema, and other proliferative retinopathies. Hypoxia seems to be the triggering factor for VEGF. So hypoxia leads to production of VEGF. Importantly, it says other angiogenic growth factors. How many are there? We have no idea. We know what we know, we don't know what we don't know. So we've identified a few of these factors, but more than likely there are many others that are playing a role. Until they're identified, it's sort of like trying to stop crime by going after murderers and bank robbers. You get rid of all of them and then there's no crime. Well, that's not the case because there's other types of crime. So there are a lot of factors. But what VEGF ends up doing is affecting these endothelial cells and leads to leaky blood vessels and growth of abnormal blood vessels. It causes blood vessels to sprout from the existing capillary bed, much like weeds growing on the lawn. And VEGF's not alone. There are a lot of other factors mentioned here that do play a peripheral role. Some we've identified, some we haven't, some we have mechanisms to block, some we don't. So we're really just scratching the surface of this, and I think there's a long way to go in terms of research. So this was the verse for the meeting theme, and we ask, where comes our help? And the help comes from the Lord and smart people that are blessed with knowledge, insight, wisdom, and curiosity to figure these things out. So let's look at a little bit of the history of what some divinely inspired people have figured out. If we go back to 2004, that's when Macagen came on the scene. Pegaptinib is the chemical name for that. And that was a big splash. This was the first anti-VEGF injected in the eye. It was a big hit and thought to be a big breakthrough. A year later, bevacizumab or Avastin came on the scene. Monoclonal antibody, so a little bit different. A year later, Lucentis. Lucentis was going through clinical trials during this time. And then finally, aflibercept, or Ilia, which is a fusion protein. So Avastin and Lucentis are monoclonal antibodies. That's the difference, and I'll go through that in a couple slides. But that's the timeline. Macagen came on the scene with a big splash, the article in New England Journal, big press release, the stock went through the roof. So all the prerequisites for a blockbuster drug. The problem was, if you look at those lines in the studies, everybody got worse. Sure, the control arm got worse the fastest because they weren't treated. That was the natural history of wet AMD, which we know is not very good. All Macagen did was slow down the decline. So Out here in Colorado, we ski, and the Macagen line would be a green slope, and the control would be a blue slope. They both reach the bottom eventually, one a little faster than the other. So along came Phil Rosenfeld, a smart guy at Bascom Palmer in Miami, with a spark of inspiration. Noticed that there's this drug called Avastin that's on the market now for treating colon cancer. And it's an anti-VEGF. It stops blood vessel growth. And he had a lot of patients that were getting treated with PDT or Macagen. They weren't responding. They had fluid, blood. And he thought, well, let's give them Avastin, see what happens. They gave it intravenously. Lo and behold, wow, it worked. So that was his first bit of inspiration. Secondly, he thought, well, what if we take a little bit of this and inject it in the eye? Well, how many of us are injecting cancer drugs out of the bottle into an eye? It was a big leap of faith, but they did it. They did a few patients, and wow, lo and behold, it worked. And the rest is history. He presented his results at the ASRS meeting in 2005. Word spread like a tsunami through the ASRS meeting about the newly discovered benefits in wet AMD from off-label and key, very inexpensive chemotherapy agent for colorectal cancer. At the beginning of the meeting, only a handful of doctors knew anything about Avastin, but at the end of the meeting, everybody went home and said, where can I get this? I want to use it. And history was changed. Shortly thereafter, Lucentis was approved. And look at the curve. All of a sudden, we are improving vision. The control arm in this study was standard therapy at the time, which was PDT. And all PDT did was slow the decline. It didn't preserve vision. It didn't improve vision. And this is the first time we had a treatment for macular degeneration that actually improved vision. After 3 injections, the vision kind of peaked out and maintained with monthly injections. So what a huge breakthrough. We could finally, and for the first time, improve vision, something previously unheard of. So what's the difference between these two? Both developed by the same company, both from a mouse monoclonal antibody, and the antibody fragment was humanized since it was going to be used in humans and they didn't want it to cause an immune reaction. So for Lucentis, they used just the antibody fragment, whereas Avastin is the entire antibody. Smart people at the time, including those at Genentech, said, whoa, Avastin's 3 times the size of Lucentis. It's way too big, it'll never cross the retina, it won't work. Well, we know otherwise. So despite the large size, it certainly did work and seemed to work comparably. Well, were they comparable? That question was answered in the CAT trial. Big study sponsored by the National Eye Institute comparing Avastin and Lucentis. A 2-year trial, and the conclusion was they're equivalent. They both work well, similar safety. And other studies confirmed this. They did a bunch of studies in Europe. Europeans didn't really want to believe the Americans, so they did their own studies for their own health financing boards to see if we're trying to pull something shady on them, but lo and behold, every study had the same result. And you can see all 4 groups are quite comparable. The only small difference is that treating monthly seemed to give a little better result than treating on an as-needed basis. But this is a couple of letters over the course of a year, so really not a significant difference. A few years later, here we are with Ilia. As you know, the FDA requires 2 phase 3 trials. One trial could be a fluke, they want a second trial. So that has good and bad. It adds to the cost, it adds to the time, but it does confirm things. So the 2 VIEW trials were the trials to get Ilia approved for wet AMD. In the VIEW 1 trial, Ilia every 4 weeks, the yellow bar, outperformed Lucentis, which was the standard treatment at the time, and it outperformed Ilia every 8 weeks. But lo and behold, the VIEW 2 trial kind of showed the opposite effect. Ilia every 4 weeks was the worst performing, and Lucentis won out. So when they pulled the data, Ilia was comparable to Lucentis and was approved, and we've had it available for a number of years now. But this is the rationale why, when you say drug approval process is slow, they require 2 trials to confirm things, just in case one is a fluke. So what about some other disease states? It's not just AMD. Diabetic macular edema and vein occlusion Avastin works quite well, but again, it's off-label. Lucentis and Ilia are approved for this. Ozurdex and Iluvien are both intravitreal steroid implants, and they're approved. Ozurdex for DME and vein occlusion, and Iluvien just for DME. Well, how are the anti-VEGFs in comparison to each other for diabetic macular edema? We had the CAT trial. So the DRCR-NET did what's called Protocol T, which is one of their mini studies, and compared all three drugs. And the top graph shows that they're all pretty much the same. Ilia might have outperformed by a letter, but that's not clinically significant. All three work quite well. They did stratify based on visual acuity and found that eyes with worse vision did a little better with Ilia. So there was a trend for worse vision, presenting vision. Ilia did better, but for the bottom three lines, the eyes with relatively good vision, all three did the same. So what's the difference? Well, follow the money, as they say. There's a big difference in terms of price if you look at what these drugs cost. And you hear about drug costs and expense and Medicare going bankrupt, and well, here's a big part of it. So this is the big difference between the three. They all work well, but there's a big difference in price. So what about practical uses?
2, 3.
This is a video of how I did injections a few years ago, just for interest. There's three ways of approaching these injections. Do monthly dosing.
2, 3.
The label says inject every month. Well, when do you stop? That's not really clear. The FDA never gave us that answer. Treat and extend is the most common way to treat. You treat
2,
until
3.
dryness is achieved and then gradually extend the treatment interval. Lastly, as needed or PRN treatment, you treat until they're dry and then stop treatment.
Good.
Watch, retreat as needed.
2, 3.
Treat and extend seems to be the most popular.
2, 3. 2, 3. 1, 2, 3. Going in.
Doing injections now, you can see the silver lid speculum has been replaced by flesh-colored lid speculum.
1, 2, 3. Going in.
Come a long way with injection technique. When we started doing these injections, we were using antibiotic drops before
1,
and
2, 3. Going in.
The next day, we were bringing them in a few days later. Nowadays,
1,
no
2,
lid
3.
speculum,
Going
no
in.
antibiotics. We don't call the patient, they just come in for their next appointment. We give them instructions, of course, but
1,
things
2,
have evolved quite a
3.
bit.
Going in.
So what's my approach? I usually use Avastin first line for a number of reasons. It's less expensive. We don't have insurance hassles. We don't have to get pre-authorization most of the time with Avastin. And we don't have Big Brother watching us. Our costs are being tracked. Medicare, private payers. Each of us in this room that are treating patients, they know what it costs for us to treat various disease states. They're keeping track of that. I usually do 4 to 6 injections before I switch. I only have 3 medicines, so I don't want to give up on one too soon. So I make sure it's really not working. And the questions I ask myself, is this no response or a suboptimal response? What's the potential vision in the eye? If I switch medicines and dry them further, is that going to make a difference in their vision, or are they going to see the same? Is it the better or worse eye? And should I just stop and watch? Injection fatigue certainly occurs, and patients do get tired of injections, and sometimes it's best just to take a break. So what's the vision potential for these eyes? The slide on the left, a lot of fluid, not much in the way of scarring. You dry that up, they'll have a noticeable improvement in vision. The middle one, yeah, some central fluid, but also some scarring. So they'll have a small improvement. The one on the right, they're pretty dry centrally. Centrally, the fovea is sitting over some atrophy and fibrosis. There's a little fluid to the side. You can treat that, and the patient probably won't notice any improvement. What about first or second eye? These are both left eyes. If I'm treating the right eye, it makes a big difference what's going on in the left eye. If the left eye is the slide on the left with a few drusen, good vision, I don't have to be as aggressive. I can back off quicker. I can extend them to a longer treatment interval. If their other eye is the one on the right there, they have a lot to lose. So if I undertreat and they lose vision in their good eye, they're in a bit of trouble. So that makes a difference as well. So practical considerations. Cost, obviously, we've talked about cost. There's also patient out-of-pocket expense. Fortunately, the branded drugs have good copay assistance programs that most patients are eligible for. Pre-authorization is a must, depending on the insurance company. A lot of managed Medicare requires pre-authorization. That can take a week or two, believe it or not, so patients can't be treated during that time. Avastin, you can go right ahead and treat them. Some payers are mandating step therapy. Fortunately, we don't have that in Colorado yet, but some areas of the country, you have to treat with Avastin first. You have to demonstrate treatment failure based on the insurance company's criteria, not my criteria, what they say. And then there's also the insurance networks. If you're a high-cost provider, guess what? You may be kicked off the insurance network. And that's happened in cities. Some of the retina groups that use a lot of branded drug but deliver very high-quality care were kicked off the network in favor of the solo guy down the street that only uses Avastin. And even if the patient's not responding, they keep injecting Avastin, but they're cheaper providers. Contraindications, obviously surface infection. Allergy, I thought I have 25. I have 15 here. Uh-oh. Allergy, you say, well, any patient can be allergic to any drug, and lo and behold, we found out. I had a patient that was allergic to Avastin and Lucentis and actually had an anaphylactic reaction. We reported this in Retina a year ago. So people can be allergic to drug. Thromboembolic events, it's a theoretical risk. It wasn't really proven in the registration trials, but if patients have had a recent heart attack or stroke, if possible, we like to wait a few months before injecting. Side effects, irritation, very common with the anesthetic, the betadine. Corneal abrasion, want to avoid eye rubbing. Subconjunctival hemorrhage, it happens, it's just bad luck. Some eyes will get a bleed. Floaters are common because we're stirring up the vitreous. Endophthalmitis is a small risk, kind of on par with cataract surgery, so not very common. When we inject floaters, or inject medicine into the vitreous, we stir it up, so floaters are common. Silicone oil droplets have been an issue with the Avastin syringes. Silicone oil is used to lubricate the syringe, and these are benign, but the patient may notice them. Oil-free syringes are available, but cost prohibitive. But in the good old American way, the lawyers are out there trolling for cases, so life goes on. Other uses of anti-VEGF, pseudophakic macular edema, uveitic edema, rubeosis. An eye like this, you inject with Avastin, come back the next day, all those vessels are gone. Other causes of proliferative retinopathies, including ROP and diabetic retinopathy. Anti-VEGFs are at least as good as PRP, less field loss, less chance of exacerbating macular edema, but the concern is if they get lost to follow-up. You can't do a couple injections and then, as diabetic patients are prone to do, disappear for 4 months and come back and they're a lot worse. And there's a big cost difference. Monthly Ilia for a year is about 10 times more expensive than a few sessions of PRP. PRP has the advantage of being a permanent effect, and it can be completed over a few sessions and done. Available treatments are Avastin, again off-label. Lucentis and Ilia are both on-label and approved. The dangers of anti-VEGF. You can do a few injections and an eye can go from what you see on the left to what you see on the right as the vessels contract and scar tissue develops. With anti-VEGF, it'll happen quicker, so that's why follow-up is important. And if a patient's not reliable, there's a danger there. Same thing can happen with laser PRP, but it'll happen a bit slower, and you can catch it quicker. Ilia inflammation, there was a cluster earlier this year. We saw a few in our practice. It's basically sterile inflammation, but you have to treat it as endophthalmitis. Patient comes in a couple days after injection with a small hypopion and some fibrin. Well, that's endophthalmitis until proven otherwise. It seemed to be associated with a particular batch of syringes and fortunately resolved. So as we look to the future, what's on the horizon? So we look for divine guidance and inspiration for the next generation of drugs. For the future, we're looking at long-acting agents, alternative targets, sustained release, topical, oral, gene therapy, and possibly stem cells. So the drug that's closest to getting approved is brolucizumab from Novartis. It's an antibody fragment, much smaller than the existing anti-VEGFs, 26 kilodalton, half the size of Lucentis, 1/6 the size of Avastin. Therefore, you can inject more per volume, meaning it'll last longer. So hopefully it will be approved as a 12-week drug, because in the studies it was non-inferior to 8-week Ilia. The phase 3 trials are completed. We're fortunate to be involved in this trial, and we're awaiting FDA decision. What it's going to cost, anybody's guess. Allergan also has a long-acting product, a DARPin product. Again, it's quite small. You can inject more, and it's a 3-month drug, hopefully. And those are in phase 3 trials as well, which we're involved with also. Alternative targets. Opthea has a product that targets the other forms of VEGF. Well, I just mentioned that those are embryogenesis, lymphangiogenesis. Well, they seem to think that there's a role combining it with VEGF-A inhibition, so these trials are ongoing. They're in phase 2 trials, and we'll see what happens. Sustained delivery. Genentech has developed a port system that's implanted surgically through the pars plana and can be refilled with Lucentis. So it turns this disease into a surgical disease, not a big surgery, but at least the Lucentis can be injected every 6 months, every 9 months to refill the reservoir and provide sustained delivery of drug. This is exciting. We're involved in this trial, and it looks promising. Phase 2 are underway, and phase 3 hopefully starting. There's a company called Greybug, interesting name. They have a tyrosine kinase inhibitor. Tyrosine kinase is upstream from VEGF, so you're working further upstream, biodegradable nanoparticles. So we're getting into the high-tech world here. Unfortunately, this is only an animal study, so it's going to be a while before we see this. Topical therapy. Ocon came up with an eye drop a few years ago, topical anti-VEGF. We were in this trial, very easy to enroll. Patients were delighted to take an eye drop rather than get monthly injections, but lo and behold, it didn't work. Biogenics, another company, came up with an oral anti-VEGF. Again, very easy trial to enroll. Who wouldn't want to take a pill once a day instead of getting injections? Phase 2 studies didn't work. Ophthalmology is looking at complement factor 5, which is the arrow at the bottom of the very complicated complement cascade that you all learned in medical school. Phase 2 trials are going on. Interestingly, this works for wet and for dry. And we're in these trials, and it's exactly the same drug that's being injected to treat wet, to treat dry. So how about that if that's approved? You could treat all comers. Gene therapy is kind of new. It's a company that's looking at delivering genes via an adenovirus vector. The gene codes for anti-VEGF. So basically, it's an anti-VEGF factory that you're injecting under the retina. Problem is, it's a surgical procedure. It's a subretinal injection, so it's a bit involved. Phase 1 trials are ongoing, and phase 2 will be hopefully starting next year. And then lastly, stem cells. Everybody hears about stem cells. They're in the news. In London, there were a couple patients that received stem cells and apparently gained some vision. Haven't seen it reported in a peer-reviewed journal, but Sky News is all over the case, and the UK Daily Mail, so how true it is, who knows, but that's been receiving a lot of press. The bad is what you've probably heard about in Florida, of patients going to unapproved stem cell clinics, being injected under the guise of a clinical trial, and really they were injected with fat cells. There might have been some stem cells in there, but most of these patients went blind. So stem cells are not really there. Patients ask about them, but hopefully someday we'll have a treatment for it. And lastly, I want to throw out a prayer request to the group for 2 of our children. I have a 30-year-old daughter that's been suffering from chronic intractable migraines for at least half her life, and she's going to be starting on a new anti-migraine medicine that was just approved. It's a monoclonal antibody, which is quite relevant to this talk, and we're hoping it helps her. And my youngest son, age 25, is having a heart valve surgery coming up. He was born with tetralogy of Fallot, which you all know from medical school. He had surgery as a child, and as is the case, most of these kids, when they reach adulthood, have problems with their valve, and he'll be getting a new pulmonary valve in August, and appreciate prayers for both of them. Thank you very much.
Once you make the switch from Avastin after 4 to 6
not really. Everybody has their favorite. Lucentis is now in pre-filled syringes, which is a convenience factor. For some, it's practice economics. The reimbursement on these drugs is extremely complex with rebates and volume discounts, all of that. For me, it's whatever's been working. It's kind of the last patient example of whatever I've been having good luck with is what I'll go to second line. I personally don't think one is better than the other. There may be certain states like pigment epithelial detachment that theoretically do better with Ilia, theoretically, because I have some that go away with Avastin. So again, everybody has their favorite. It's like, you know, what kind of socks you wear or what kind of golf ball you use, and you think you hit the ball further, and you probably don't. Yes?
Do you think that cheaper is there than aflibercept would be available soon?
Well, it depends what you mean by available. Aflibercept is available now for treating cancer. It's very much like Avastin. It's a systemic agent given intravenously as an adjunct to chemotherapy. But it's basically Ilia with a little bit of modification. And Regeneron was quite certain that they wouldn't have an Avastin problem on their hand. They played with the pH and were quite sure that couldn't inject it in the eye. But unfortunately, their studies were in a rabbit eye, which is a lot smaller, human eye's bigger, more dilution. Lo and behold, you can inject it into a human eye. So it has to be compounded like Avastin. In the US, not particularly popular because we have the branded drugs available and insurance pays for them, although reluctantly. When Avastin came on the market, we had nothing. But in other countries, developing countries, aflibercept is a very good option, and I wrote a paper on that in Retina Today a couple years ago, kind of outlining that, and it's, I think, a good approach, especially in third world countries that just can't afford these drugs. It would at least give them an alternative to Avastin at an affordable price.
So I just want to take a moment to pray for Brian's kids, if we bow with me, okay? Heavenly Father, we thank you that you are the great physician and the ultimate healer, God. We just ask, as a group of believers who come to you together in your name and pray that you would be with Brian's kids, God. Would you please bless them? Would you watch over them? Would you protect them? God, would you heal them? Would you give wisdom to the doctors? And we ask, God, more than anything, that you would be glorified above and beyond anything, God. Bless Brian, give him patience, give him trust and faith in you alone, knowing that you have his kids in your hands, God. Bless their family in every way. Amen.
Thank you.
Thanks, Brian.